Salam alaikum, Dr. Rechichi, right, Miguel?
Yes, أنا سعيد لكوني هنا. Arabic is not so good, but
Mashallah.
I'm
Mashallah.
trying.
Yes, it's good. It's very good. Do you want to continue in Arabic?
Next interview, I will
Yalla,
promise. I will
next
promise.
one. It's okay. Is it your first time in Abu Dhabi, as in a congress?
Yes, for a conference, yes.
Yes. And how did you find the congresses and?
The congress I find a really high quality,
Yes.
and also the organization is wonderful.
Impeccable. Yes.
Really. Honestly, it's 10 years that I go around all the UAE. I was in a lot of places, and in these 10 years, I saw a very grew in the quality of the Congress. Organization was always fantastic, but the scientific quality really grew in these 10 years.
Yeah. So Dr. Miguel is from Italy.
Yes,
And the south of Italy. So you're a Mediterranean.
absolutely.
So we understand each other, you know, Morocco and Italy. Dr. Miguel is a specialist in cornea and in cataract and
Yes.
now soon in retina.
I'm transitioning, yes.
Transition, you know, he wants to do it all. And next year he will tell us in eyelids, you know.
The day is just 24 hours.
Of course, we can do anything. So tell us a little bit about yourself. How did you start? When did you start? What did you do as fellowships?
Okay. It's a long story. We have just a few minutes. So my history is the history of a normally guy who had a big passion for medicine, big passion for technology. And honestly, I found during my medicine school that ophthalmology will be my life because it's the most technological specialty in medicine. So my father was an anesthesiologist. My mother was a specialist in pulmonary disease. So my background is medicine, but honestly, ophthalmology was a passion. I grew like a nerd. I was an hacker. My passion
I
was...
figured it a little bit when you told me you get bored and you want to do vitreoretinal. I was like, he's a nerd.
Yes, it's like this. And then also cornea and refractive surgery is the most advanced in technology, the subspecialty of ophthalmology. So
Yes.
it will be, I know that it will be my life.
Yes.
Actually, I'm also developing the cross-linking technology with my close friend, Professor Cosimo Mazzotta. And in these 10 years, we developed all the new protocols for accelerated cross-linking. We combined this technique with the refractive surgery, and now we are trying to do also to combine also with additive surgery like CARES, cross-linking CARES. So this is actually my field of research.
Of expertise, right. So cornea has evolved so much in a few years that has been 10, 15 years. It's just amazing what we are doing right now, especially with the CARES. There has been in the market for like 6 years, 8
Yes.
years. And are you, do you prefer to have cornea other than PMMA?
Yes, absolutely.
For the rings,
No, the future will be allogenic. This is the truth. PMMA, helps us to know how the cornea could remodel, but a lot of problem. Allogenic tissue, honestly, is a tissue, so you have less problem. Is a little bit less predictable because they shrink, but we calculate this but the future is this.
Is this?
And it's also a way to recycle cornea from banks. So in a period in which always talk about recycling, it's also...
Yeah, it's the best way to recycle
Yes,
cornea.
it's ecologic.
Yeah. And having all of these years in cornea, you specialize as in Mediterranean. We know there's thin corneas, just like in Morocco. And yeah, it's not the same. It's definitely not the same. The approaches are different from the other countries where they have 600 microns and it's really not the same. So what do you do especially for those thin corneas and those special refractive cases? What have you learned? Give us, for someone who want to start refractive, and I'm talking about myself, give me the keys to engage on those touchy corneas.
Yeah. And are you speaking just about normal cornea or keratoconic cornea? Because
normal cornea. Let's talk about those patients who want to do refractive and you find yourself... do you use just Pentacam? What the tools that you use?
So actually, I use Italian technology, CSO.
Ferrari.
Yes, Ferrari. Actually, my Ferrari is a MS-39.
Of course.
That actually I'm always...
MS-39 is Italian?
Is Italian, from CSO, Florence.
Wow.
And
we use it too in Morocco and in France, and it's the reference.
We also did the work to link with the excimer laser that I use. I'm a Schwind user and developer. And actually, the best technology is to link these two devices because it takes in account epithelial component, stromal component, and also posterior component. And I will talk about this because in normal eyes, it's all easy. You can do with every machine. But when you have irregular cornea or you want to regularize a keratoconic cornea, you have to take in account the epithelium and the contribution of posterior surface of the cornea. And you can do only with the ray tracing technology that actually is MS-39 based. And actually the link with the Schwind is one of the only option. No, there is just another option in the market, but actually is the best option to treat all the aberration that comes from epithelium and posterior.
Okay.
So actually, this is my Ferrari.
Okay. I totally understand because I think it's the best on the market right now. It really is. And you see so many topographies who are totally normal and you discover so many things on MS-39.
Yes. What about the thin cornea?
What about the thin cornea?
The thin cornea.
What is for you a thin cornea? Less than 500?
Yeah, in a normal cornea, less than 500. Honestly, in my country is the 50% of the...
Yes, well, and even in Morocco.
What I learned now, is that after 15 years of seeing post-ectasia, post-refractive surgery, is that PRK surface ablation is still the best option.
Yes.
It's still the best option. Also for cornea which are close to keratoconus, so in the suspect cornea. And honestly, I saw a lot of patients with keratoconus not diagnosed. One eye with the PRK, one eye with the LASIK. The eye with the PRK did not progress. Yeah. The LASIK was a disaster. But now, as a cornea specialist and also as a refractive surgeon, we have another big option that is intraocular surgery. So honestly, what I try to teach to my residents and also into the Congress is when you have any suspects, you can have access to phakic IOL. This is a really game changer.
Yes.
You will sleep well.
Yes.
You give the best quality of vision because nobody speak about the quality of vision. So the phakic IOL really give sometimes a quality of vision that is better than
your
laser
lenses and your with your lenses.
Absolutely.
Yeah.
And you can use sometimes in very selective cases, as I use, also in cornea with ectasia, which has a regular topographic astigmatism.
I totally agree with you. And I think that right now, the IOLs are actually, some doctors choose it for -4. It's not even for, they don't want to touch the cornea. Some of them are like, the cornea is too precious to be touched and I'd rather put an implant on it.
I am one of
You're one of them? I just said it, I didn't know you were one of them.
I always show in my presentation some cases of suspect keratoconus or very thin cornea in which I have to correct, for example, a big amount of astigmatism more than myopia. And in these cases, if you do with a laser, you will result in a very oblate cornea. So the quality of vision
Right.
is,
Especially at night.
yeah, the spherical aberration rise. So why don't you do on an intro? But
Yeah.
you can also do the double surgery, you know?
A little bit of PRK and
Yeah, you fix first with the intraocular surgery,
and what is left?
and what is left, you have fine tuning with the laser, not bioptics.
D'accord. Okay.
And you can do also reverse bioptic, for example, with the keratoconic eyes. So you first strengthen and regularize the cornea.
And then you
And
put
then
the
when
implants.
your refraction after 6 months, 1 year is stable and predictable, sometimes in selected cases you can put fake KUL inside.
Okay.
So reverse optics for the regular cornea, and sometimes normal bioptics for regular cornea.
I think most of the patients prefer to have their cornea touched than having something inside the eyes.
Yes.
And that is why the indication is not as widely put to patients, and they'll be like, you either touch my cornea or I'm not comfortable with the idea. How many years have you been doing the implants?
The fake KUL now
Phakic.
is more than 7 years.
7 years. And those 7 years, how many cases have you seen where you should have put out the implants because it did some side effects? How many side effects?
Honestly, in actually more than 1,000 implants, 2 times.
Voilà.
2 times.
So the patient is scared more about the side effects, but it's not really that common.
No, but I always tell this to the patient. The fake KUL actually is the only reversible surgery.
Yes.
When you do some disaster in the cornea,
It's done.
you can fix, but it's not so easy. And you will never return to the starting point. Fake KUL, the only issue, the only real issue is infection. But like laser surgery, probably a little bit more scary, but it's like the number are similar, close to cataract surgery. Something less because the surgery is so smooth.
So smooth.
And honestly, I tell to the patient that sometimes I have to think also the quality of vision
Yes.
and also the reversible option.
Yes, and the aberration is so much less than LASIK sometimes.
This is the fact.
Yeah,
This is the fact. I study all these kind of things with the barometry now, and if you see the quality of -6 with the fake QL and the
has
quality of
nothing.
fake and the quality of -6 with the laser, is another
Nothing.
history.
Yeah, it's another history.
And remember also the magnification effect of these lenses. You have 18% magnification, so the patients say could see well, and they can see much more well than before surgery.
Yes. And do you do ultrasound for the IOLs systematically for the implants? UBM ultrasound to see the ciliary body and where you're gonna put
Yes.
because it's controversial. Some say, oh, it takes a lot of time.
I will tell you the real history.
Okay.
If you put just spherical IOLs, you do not need two, because the real reason why you have to do ultrasound, UBM, in each patient in when you put a toric IOL, because some patients have a cyst in the axis.
And it switched a little, it tittles.
And
it
in
goes,
some
it
way
moves.
can tilt, but
Tilt.
can also rise the iris and get some shuffling, so it's important to do, especially if you do toric IOL.
Okay.
Now, honestly, in my practice, I do each patient with a UBM. Especially
Did
now.
you have surprises without the UBM?
Sometimes, especially with the toric IOL. When you do that toric IOL, in some way, the lens, by the time, usually find itself the best position. But if you have a toric implant and you notice that your lens move, you have two problems. The main problem probably is the size, is 80%, but 20% is a hidden cyst.
Yes, yeah, of course. We don't know until you have some...
Honestly, if you start this kind of surgery, do
the UBM, yes. So we talked a little bit about the ophthalmology. Now we want to know the man behind it, and I feel that ophthalmology is actually your passion, but do you have another passion other than ophthalmology, or?
I have a list of passion.
Oh, la, la, la.
The most strange probably is kite surfing. I live on the sea, and I love the sea. I cannot live in a city without the sea.
Of course.
So honestly, kite surfing is my great passion.
Okay.
I go out.
So you should come to the Moroccan Sahara, in
Yes,
in Dakhla.
In Dakhla,
Dakhla,
yes.
of course. There's the biggest kite surf there.
Yes.
Of course.
El Aswiri, I think also.
Sawira.
El Aswira.
Yes.
I come 3 times Morocco,
Ah.
and most of my colleagues are very close to Morocco people.
Okay.
Really, really.
Yeah. So you kite surf other than kite surf?
Alexa, I love the. I'm a fan of electric car.
Okay.
Yes.
A real geek.
Really? Because of the technology, I'm a really fan of motors.
Okay.
Yeah.
And we talked about how passionate you are about refractive, and I had a question for you before we started.
The big question. I know
the
it.
typical question.
Yes.
If you operate patients on refractive, why do you keep classes?
Okay, this is what I always tell to my patient, and this the question that I push to know if the patient will be good.
Okay.
Not for the cornea, but for psychologically.
Trust issues.
Yes. I'm very close defect. I'm a little bit astigmatic, like minus 0.75. So I really do everything, my sport without glasses. Actually, I'm just using it just for presbyopia or
And for the style.
or for fine tuning, but I will do the rest of the interview without the glasses now. And I tell to the patient, zero does not exist in nature. So I cannot promise the zero, and I cannot promise the zero for all your life. Refractive surgery is to get not totally rid, but less dependent from spectacle.
Yes.
But everything will getting out. Everything will be presbyopic. And also presbyopia surgery now is a compromise. There is not
No perfect.
not the perfect solution, and not the perfect solution for every.
Yeah.
I always, when the patient asks me more than 5 questions, probably is not a better patient for refractive surgery. So,
what is a red flag for you? I asked this question actually on the SRS, and I told many ophthalmologists, what is the red flag for you? And we know Matteo Forlini.
Yes.
You know what is a red flag?
Yes.
Is a woman with 3 cats.
Yeah, that is a good answer.
That is a red flag for him to touch. What is a red flag for you in refractive?
Obsessive compulsive patients. Most of them are engineer. Because they are struggling with math. For them, math is perfection, but medicine is not perfection. And those people who cannot accept compromise, no? I know it, the easy character, okay? If your patient is an easy character, very happy, very proud also to changes, is a good patient. This patient asks a lot of questions, a lot of mathematical questions. Probably they will expect more than you can offer.
Yeah.
So the real problem, and this work for refractive surgery, also cataract surgery. Cataract surgery really changed. 10 years ago, the people just want to get rid of the cataract. Now the people want to see better. Yes, without any compromise. And honestly, now I think that 10% of my consultation about refractive surgery, I just tell, okay, go. Not, I will not operate you.
Yes.
I'm not the right surgeon for you, because I can promise all real things.
Yes.
Okay? If you want anything that I cannot realize.
And I think that patients appreciate a surgeon who tells them, no, it's not always possible, other than the surgeon who's like, we can do everything, come. And I think that is a great thing to have nowadays, because refractive is kind of scary. The field of refractive is just like, sometimes it's turning into a business that could be scary. And to have an ethical doctor who's going to tell patients, no, it's actually a sign that is a good doctor for me.
I can say something that probably is not politically correct, but I think that the big difference within patient expectation and the surgeon is the marketing. Okay, sometimes the marketing that is not made by surgeon push versus perfection. Okay, so the patient go to see
High
the market and go on YouTube
yeah.
and see the marketing of my clinic, your clinic, any other clinic, and get rid of the glasses for the life.
Voilà. And I'm actually going to talk about this, the ethics of social media, because nowadays it's crazy what is happening right there. It's like over exaggerating the patient's expectations, and he is waiting for that super view.
The patient comes to you with all the ideas in his mind. It's not a consultation. Sometimes the patient treats you like you are just the hand.
Yes,
the
I know.
hand.
I want this and this
I
and
want
this.
You will be you. I want your hands.
Yes.
No, this is not a consultation.
Exactly.
So
exactly.
the patient have to trust in the surgeon and what the surgeon tell. Then, if the surgeon promised the moon, is a matter of the surgeon. Okay. And this is the reason why I do not promise the moon. I promise improvement where I can, not more. And if the patient don't trust me, go away.
Exactly.
I want another patient, another happy patient, not another
Angry
unhappy
patient. Unhappy,
patient.
yes. Especially that it's not something that should, it's a necessity. It's just a luxury, let's face it, let's say it. So a luxury should not come at the cost of your eye.
As a refractive surgeon, we operate normally people.
Yeah.
Okay? People with a normal
life. They don't come to you because they're dying.
Yes. So we have to be sure that we can improve.
Yeah.
Okay?
Yes.
Okay?
Okay.
No, we cannot promise the moon.
Okay.
This is the
I
main source of unsatisfied patient. It's the same history as multifocal IOLs.
Yes.
Okay.
They are expecting.
Why the market is always the same? Okay. The market of multifocal IOLs, multifocal treatment, didn't grow in 10 years, in 15 years. The technology probably improved.
But the marketing is still the same, promising the
sector
best.
is always the same.
Yeah.
This is the same reason.
Yeah. Okay, so Dr. Miguel, I want to thank you for this really passionate talk. I am really passionate about refractive, but also about ethics, and especially with the social media era. And talking about it with someone who has the same view, it's a really pleasure of mine. So do you have a last advice for youngsters who want to start refractive after all of these years?
You are choosing the best subspecialty of ophthalmology, and do it just if you're really passionate, because you have also to face great satisfaction, but also some failure.
Yeah.
And as a surgeon, you have to accept and you have to work to reduce. But this sometimes takes you out on the night, asleep on the night, but honestly, you are choosing the best subspecialty in the ophthalmology.
I am totally agreeing with you. Thank you very much for being with us. It was an absolute pleasure.
Will be my pleasure.